Okay guys, here we go with lecture 2 today. Today we're going to be talking about disorders of the male genitourinary symptoms, which include penile disorders, prostatic disease, both benign and malignant, and testicular cancer. I want to give you a little disclaimer before I get going in here. If you watched the lecture before this one, those pictures were tame compared to what these are, so do be prepared that you may see some graphic illustrations this time, okay? And I know there's a lot of slides in this lecture, but there's a lot of pictures, so that'll kind of make up for it, okay? In this lecture, we're going to be talking about causes and treatments of urethral, penile, and scrotal injuries, okay? Benign prostatic hyperplasia, testicular cancer, and prostate cancer. And we'll be talking about how you can differentiate between prostate cancer and benign prostatic disease. Okay? See, short objectives, just a lot of different disorders to go through, and some of them we've already discussed in the previous lecture. Okay? Phimosis is a condition related to the foreskin. Okay? It is the inability to retract the foreskin. It's physiologic at birth, or you can acquire it. Okay, 90% of uncircumcised males have foreskin that becomes retractable by the age of 3. So if you have an infant that has foreskin that will not retract by the age of 3, it should. If it does not, then you may need to consider circumcision. Okay. Patients who acquire phimosis, this condition becomes pathologic from inflammation and scarring at the tip of the foreskin, and that usually happens from recurrent balanitis or infections, and it's commonly related to diabetes. So you could imagine as an adult, having this problem that you might want to get that treated. Children, to treat them, you can try corticosteroid creams because they thin the skin. And see if it helps. After the age of 10, circumcision is definitely recommended because you have to be thinking about erections and pain and that kind of thing. Okay. In adults, circumcision is typically recommended as therapeutic and curative. Alright, this is a picture that shows just a diagram first of some of the scarring, and it's got a little, well, of course it's in another language, but it has little arrows pointing there to where you can see some of the fibrosis that can cause problems, okay? And in the diagram, it's hard to see, but the urethra, well, the urethra itself, of course, is behind all the foreskin, but the foreskin opening is very narrowed, and it won't pull back over the penis. Paraphimosis is when the skin is pulled back, but it can't be retracted back over the glands. Okay, it leads to very painful venous stasis in the retracted foreskin with edema in the actual glands itself, and it's extremely painful. These guys are just in a whole lot of discomfort. Okay, treatment, you can try manual retraction. There's lubrication of the foreskin and glands, and then have a picture of it in a second for you, but you put your thumbs essentially on the glands and you use your second and third fingers to pull that, kind of push and pull at the same time to replace that skin back over the penis where it's supposed to go. Okay. In rare cases, emergency circumcision may be necessary. There's also a treatment called a dorsal slit where you make a little cut, of course under anesthesia, in the tissues that allows it to relax and pull back over the glands. Okay, so these are just some illustrations. Okay, this, of course, phimosis. You got this little opening in the foreskin. Okay, this is just a diagram explaining manual reduction of paraphimosis. Okay, and this is a picture of that. Thumb, finger, pull. Okay, with lots of lubrication to help prevent additional trauma. Okay, this is a picture of the dorsal incision I was telling you about that essentially cuts the stricture and lets it come back over. All right, with paraphimosis, this edema, very, very common. Okay, it's an extremely painful condition. Penile fractures seems like a joke, but is absolutely real. Okay, is traumatic rupture of the corpus cavernosum, and it occurs when the tunica albuginea is torn. It is usually associated with sexual activity, i.e., an erect penis. Well, there's a joke about it, but you hear this overzealous newlywed husband essentially comes into contact with the sheets or the bed instead of his target, and you end up with this injured state. The patient may hear a snapping sound, and there, of course, is localized pain, okay, detumescence, obviously, and slowly progressive penile hematoma, which is what you want to prevent if you can, okay. And I have some pictures, okay. The first is just a simple diagram explaining where this tunica albuginea is, okay. And as you can see, the dorsal vein is here, okay, and there's a lot of other blood vessels that are associated in here. And if you get any tearing and stuff, all the swelling is going to put pressure on the other blood supply. Okay, so this is what your typical patient's going to look like. He may look like he's in a whole lot more pain whenever you first see him, okay? But an ice pack is absolutely appropriate to try and bring some swelling down and prevent these hematomas, okay? As you can see in the top right, you have a lot of swelling and redness, which is the ecchymosis, and bruising associated with hematoma, okay? And of course, that's what you see in the bottom right as well. And on the middle there, that is probably an MRI picture. I found it for you, but the reason is because the little arrows are pointing to an area of blood flow, so that's where the actual incident has occurred with local bleeding. Okay. The treatment is mainly meant to prevent hematoma. I don't know if you guys have a lot of experience with hematomas, but hematomas are like large blood collections that form, it's almost like a big bruise deep under the skin, but it's like a clot in there. It takes forever for them to resolve, so they're not comfortable, and they're usually pretty sore until they do go away. Non-surgical intervention is bed rest and ice packs for 24 to 48 hours, followed by local heat and a pressure dressing. The pressure dressing to prevent any additional swelling, the ice for 24 to 48 to prevent any additional blood flow. The vasoconstriction slows the blood flow, less edema, okay? And then after that, local heat, because you vasodilate, it brings the blood vessels by in a different way and helps to absorb and like resorb essentially that hematoma, okay? Surgical intervention is probably the most common because hematomas need to be evacuated in most cases. Sometimes the tunica albuginea has to be resutured back together, okay? And pressure dressings, of course, will prevent that. The prognosis of this condition is that 10% will experience a permanent deformity due to the problem, and that could include that Peyronie's disease that we saw earlier, suboptimal coitus, impaired erections, especially if managed non-operatively. I mean, most of them really do need surgery. And that's, we get back to the Peyronie's disease or Peyronie's disease again. Dense fibrous plaque forms along the tunica albuginea, causing the erection of the curvature of an erect penis. Alright, and I think we talked about this in the last lecture. So flaccid penis is usually normal on exam, but the curvature is noted only in the erect penis. So this is probably going to be something that you hear about from the patient and not actually see in the office, or you may only see like in the operating room when you're getting ready to do surgery for it. Alright, there is an acute phase and a chronic phase of Peyronie's disease. I know we didn't have this slide in the last lecture. In the acute phase, pain and inflammation can present when the plaque is forming. Okay, medical therapy is modestly successful at that point. Okay, in the chronic pain, the pain subsides and the plaque is stable, but surgical correction may be needed if the curvature is interfering with intercourse. And some of them are pretty advanced, and they really can. Okay, the medical therapies they're talking about. Vitamin E, colchicines. Tamoxifen is actually a drug that's used to block estrogen, and so it may help remodeling. In the chronic phase, the pain subsides, the plaque is stable. Surgical correction, we already talked about that. Sorry, guys. Duplicate. Okay. Testicular cancer. Testicular cancer is a very important topic to discuss, okay? Because it's the most important or the most common neoplasm in men aged 20 to 35, okay? I've actually also heard that about 15 to 28. So, anywhere in that late teens, okay, mid 30s. Typical presentation is a painless nodule or a painless mass on the testicle, okay? And orchiectomy is necessary for diagnosis. So orchiectomy would mean to remove a testicle, not just to needle biopsy. Testicular cancer is considered rare. However, you do hear about it. It is something to consider for all male patients that have a testicular mass, okay? In the news you hear about Lance Armstrong, specifically having testicular cancer, but even amongst my friends in the community, I have two acquaintances who have had testicular cancer, and I don't know that many people. Okay, so it is more prevalent than what you think. 90 to 95% of all primary testicular tumors are germ cell tumors, either seminomas or non-seminomas. Okay, they can happen in both testicles or one testicle, but they are a little bit more common on the right. Okay, the lifetime probability is like 0.2% for American white males, so not very high. The cause is unknown, but 5% will have a history of unilateral or bilateral cryptorchidism. Okay, cryptorchism is a condition where the testicles are undescended, and you'll talk about that in your pediatrics lectures. The risk of malignancy is the highest for an intra-abdominal testis, okay, one that never comes down, versus an inguinal testis. Orchiopexy, which is the procedure that you use to manually move a testicle from the abdomen down into the scrotum, okay, does not alter the risk of developing testicular cancer, and it does help examination and tumor detection because obviously you can feel it. However, even though cryptorchism is a condition that can increase the risk, although very small risk, okay, most of those happen on the normally descended testis, not the one that was stuck in the abdomen. Okay. Signs and symptoms of testicular cancer. The most common symptom of testicular cancer is painless enlargement of the testicle. Okay. They may also complain of a sensation of heaviness. The patient normally detects it, but may not present with the problem for 3 to 6 months. You would think that a male who felt a lump in his testicle would be extremely anxious. However, a lot of them just think it's something normal that'll go away, or they're embarrassed. Maybe they have sexual practices that they're anxious about, or different things, and so they just don't present. They can have some acute testicular pain from intratesticular hemorrhage. That would be from the fact that tumors have blood supplies and typically can hemorrhage, but there are a few that present that way. A lot are asymptomatic at all. You may notice it on your exam of the patient, okay? And symptoms relating to metastatic disease are present in 10% of all people who present. And that would be back pain because you have retroperitoneal mets, okay? And they may have lung mets and present with a cough that's just, unending and won't go away, or lower extremity edema from either bulky metastatic disease in the nodes of the lower extremities or in the pelvis, or from vena cava obstruction. On physical exam, testicular mass or diffuse enlargement of the testis is the most common physical finding. Okay, some of them will have hydrocele as well, so don't think it's just a hydrocele. Okay, in advanced disease, you may see supraclavicular adenopathy, or you may feel a retroperitoneal mass. Okay, gynecomastia presents in 5% of germ cell tumors. Differential diagnosis for patients that have testicular masses: hydroceles, epidermoid cysts. For a lot of patients, actually 25% of patients, an incorrect diagnosis is made at the initial examination, and you're just delaying diagnosis and treatment at that point. Okay, if If you have a patient that you suspect has testicular cancer, there are some lab tests that you can do. A basic serum HCG. You could also do a urinary HCG if you wanted to, but serum is more sensitive. Okay, HCG is the test you use for pregnancy, and so men should not be making that. If they are making it, then you need to be considering testicular cancer. Okay, alpha fetoprotein can be elevated, as well as lactic dehydrogenase (LDH). Okay. Liver function tests are elevated with metastasis, so it's not a bad idea to check those. Anemia is present in advanced disease, and that's a chronic condition. Okay. So this is a picture. It doesn't really help a whole lot, but it's just an example of epidermoid cysts. Okay. All right. To really know the difference between a hydrocele and a testicular mass, I mean, you can transilluminate and see if you do or don't. If you do transilluminate, but it's a smaller area transilluminating than what you expect, especially, then I would move on to scrotal ultrasound. It can determine whether there's an intra or extra testicular mass, which would be the difference in hydrocele versus which would be extratesticular versus the intratesticular masses. In intratesticular masses, most of those are actual malignancies, but some of them can be the cysts that we just discussed. Okay, CT scans of the abdomen and pelvis, as well as CTs of the chest, are usually staging exams and are done post-orchiectomy whenever you have determined if it's actually cancer or not. Okay, radical orchiectomies are surgical treatments that can be used to control spread of disease. Okay, and then scrotal approaches and open testicular biopsies should be avoided. They don't get enough tissue, or they just don't give you enough information. You have to do additional surgery. This is an ultrasound picture of a large testicular neoplasm, and it's hard to see what's going on because it is so large, but this is a testicle all around here, okay? And this is the edge up here, okay? And this unusual gray tissue in here, okay, is the mass itself. And this is some fluid hanging out. Little hydrocele with that. Okay? Of testicular carcinomas, you have non-seminomas and seminomas. Up to 75% of stage 1 non-seminomas are cured with orchiectomy alone. Selected patients may be offered just surveillance after surgery and no chemo or radiation. In the seminomas, you have stage 1 and stage 2. They're treated with radical orchiectomy and retroperitoneal irradiation. They have a 5-year disease-free survival rate of 92 to 98%. Okay, that's really good. That's an excellent survival rate. Okay, stage 1 cancers are less than 2 centimeters, and they may be candidates for surveillance alone. They may not even need that radiation we were just discussing. Okay. Stage 2B and 3 are greater than 5 centimeters in size. They're treated with primary chemotherapy. Okay, after their surgery. Surgical resection of residual retroperitoneal masses is warranted for masses greater than 3 centimeters. Okay, and the reason for that is because 40% will harbor residual carcinoma. So that's why instead of just doing chemotherapy and letting it go because the mass has gone away, many will still harbor residual carcinoma, and so you do need to get in there and get that testicle out. And the reason you do the chemo first is to prevent the spread of disease. Some will need radical lymphadenectomy or a modified radical lymphadenectomy. Modified radical lymphadenectomies can preserve erectile function versus the radicals, which patients may have a lot of trouble with erectile dysfunction afterwards. Surveillance is an active process for the clinician and the patient. And surveillance, we're talking about very, 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 very close follow-up. And you really do have to follow cancer patients closely. For testicular cancers, relapses are most likely to occur in the first 2 years. 80% of all relapses for testicular cancer occur in the first 2 years. So you have to watch very closely. And it's not just something for the clinician. I mean, yes, it is important that you see your doctor every for testicular cancer every month for 2 years, and then bi-monthly in that third year. But you also have to be doing self-exams at home. It's not enough just to do one or the other, okay? And it's also important to check tumor markers and make sure they're not rising at those visits, okay? Tumor markers, like we talked about for this one, would be HCG, alpha-fetoprotein, and LDH, okay? Chest x-rays and CT scans looking for adenopathy or metastasis should happen every 3 months versus the actual physical exams and tumor markers, which should happen more frequently than that. Most relapses, when they do occur, can be cured with chemotherapy or surgery, and there are alternatives to having to surveil so closely, and that would be retroperitoneal lymph node dissection to if you don't have the nodes there, you can't develop the disease there, okay? Or adjuvant chemotherapy, which you'd still have to do follow-ups, but just less frequently. The prognosis of testicular cancer: 5-year disease-free survival rates for stage A non-seminomas, 96 to 100%. Even stage B is 90%, which is phenomenal. Of the seminomas, stage 1 and 2A, 98% are 98% of the stage 1s and 92 to 94% of the stage 2s are still alive at 5 years with no disease recurrence. Okay, of stage 3s, 95% are still alive at 5 years, and those patients who had orchiectomy and chemo. And patients with bulky retroperitoneal or disseminated disease, that would be like metastasis, okay, with primary chemo followed by surgery, 55 to 80% are alive at 5 years, okay? And so, as you can see looking up through there, it's just like it is with most of the other cancers. The earlier you find it and take care of it, the better. So the key to excellent prognosis is early detection and intervention. Well, the only way you're going to get early detection is through a patient finding it and telling you about it quickly, okay, not keeping secrets from you, for one, or from actually doing very good exams and finding things. It's very easy to skip over a good testicular exam just due to, the patient having awkward feelings toward the exam and you having awkward feelings towards that exam. And later in your education, you're going to meet these people that teach you how to do genitalia exams, and they will tell you how to do a very, very thorough exam. Alright, now we're going to talk about prostate disorders. This would be a good place to take a little break. If you need a break, push pause on your lecture, just because it's a little involved between benign diseases and malignant diseases. Alright, the prostate is located in the pelvis, surrounded by the rectum, bladder, venous complexes, and neurovascular bundles that are needed for erectile dysfunction, okay, and also surrounded by the urinary sphincter. And I have a picture of that in just a second to help you with that, okay? The functions of the prostate are to produce PSA and prostatic acid phosphatase, okay, to express androgen receptors from that hypothalamus pituitary axis we talked about in the last lecture, okay? And in the prostate, testosterone is converted by enzyme 5-alpha reductase to dihydrotestosterone, okay? The periurethral portion of the prostate increases in size during puberty and after age 55 due to growth of non-malignant cells in the transition zone. Most cancers develop in the peripheral zone and can be palpated on DRE or digital rectal exam. Alright. This is a picture of the prostate gland, okay? So let's see what we have here. We have the bladder, okay? You see the prostate sitting right here. Alright, and then sphincters, okay? So you can imagine if this gets bigger, sphincters get blocked, okay? And that way it's difficult to pass your urine and that kind of thing. This is a diagram with the zonal anatomy, so we can try the transition zone is right in here, okay? And the peripheral zone is right out here. That's why, since these tumors develop out here, They're much closer to the surface, and so they can be palpated. Benign prostatic hyperplasia. Very, 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 very common problem in men, okay? Patients may present with obstructive or irritative voiding symptoms, okay? They may have enlarged prostates on rectal exam, and they may have no urinary tract infection, neurologic disorder, stricture disease, or malignancies. The definition of BPH is a smooth, firm, elastic enlargement of the prostate. It is the most common benign tumor, okay, or growth in men, and it's growth of the whole gland, okay. The incident is age-related, and you can see there that as you increase in age, the incidence increases. Symptoms of obstruction are also age-related. 25% of 55-year-old men report obstructive symptoms, okay, versus 50% of 75-year-olds reporting obstructive symptoms, including decrease in force or caliber of urinary stream. There's multiple causes, but two factors are generally necessary for development. An endocrine factor, which is high levels of DHT, okay, or aging. And this is just a diagram showing that that incidence does increase with age. Obstructive symptoms would be hesitancy, you feel like you go and you can't. Decreased force and caliber of stream. Whenever you do go to the bathroom, they notice that it used to come out real fast and real hard, and now it's just weak. That's the best way they'll describe it, okay? They may describe a sensation of incomplete bladder emptying. It feels like there's still pee in there. They feel like they still need to go, but they can't get any more to pass, and then they end up going back again just within a few minutes or within an hour. And the actual definition of double voiding is urinating a second time within 2 hours, okay? They may feel like they're straining to urinate to pass past something, okay? And they may describe post-void dribbling. You'll hear a lot of guys talk about that, actually. Irritative symptoms, urgency, frequency, nocturia. They can have infections or they may not have infections that go along with this prostatic stuff, okay? Alright, this link is probably not going to work for your virtual lecture, but it is table 23.4 in your CMDT, and it's an excellent symptom table for BPH. It's actually considered probably the most excellent tool in determining how severe a patient's BPH is and whether they need treatment and what kind to recommend. Okay. In the differential for patients complaining of these symptoms, you have to think prostate cancer, BPH, urinary tract infection, neurogenic bladder, urethral stricture. I mean, lots of things to think about. Okay. On the physical exam, you do a digital rectal exam. Patients do not like digital rectal exams. I have not heard a man yet who wants a DRE. They are not the easiest exam in the whole world to get somebody to do. However, they are extremely valuable, okay? Whenever you palpate that prostate, you need to know its size and consistency, okay? The size of the prostate doesn't necessarily correlate with the symptom severity or the degree of obstruction that they're feeling, okay? But it's still important to note, is it large? Is it boggy? Is it normal size? Is it elastic? Is it firm feeling? What does it feel like, okay? If it's indurated, you need to rule out cancer, okay? A focused neurological exam like we talked about in the ED lecture, making sure that they can feel everything down there, that they're not having problems related to a nerve that's not working, okay? And then examine the lower abdomen and see if their bladder is distended. If the obstruction is severe enough, they might have a distended bladder from the fullness if they can't pass their urine, okay? What should the prostate feel like? That's an important question. That's something that you'll learn with your GTAs that teach you how to feel genitalia, okay? But it should generally feel smooth, and it should generally have 2 lobes and feel about the same side on either side, okay? I also meant to put in this question, what does induration mean? And induration is thickness, fullness, hard very hard or raised. That's what that means. Okay. Labs that may be abnormal with BPH, they may have renal insufficiency. We've talked before about chronic renal failure and its incidence with obstruction, those chronic tubulointerstitial diseases. Okay. Their PSA levels may be elevated. Okay. Urinalysis can rule out infections, or may also show some hematuria from the prostate being enlarged. Other studies that you can do are transrectal ultrasounds to get an actual look, see if there's a hard mass in the prostate. They're not usually done, but they can be done. They're not usually done in BPH. They're usually done if you feel a mass. Biopsies can be done. Those are done by urologists. Okay. Cystometrograms and urodynamic profiles are reserved for patients that you suspect have neurologic disease or those who have failed prostate surgery to debulk their prostate. All right. Elevated serum PSA. PSA is a useful test, but it's not useful by itself. You have to do your digital rectal exams as well. And digital rectal exams are okay, but because of BPH, they're not good alone. You also need to do the PSA to help you differentiate between developing cancers or other things. So we're going to talk about PSA a little bit, okay? The differential diagnosis with an elevated PSA: prostate cancer, glandular hyperplasia, acute bacterial prostatitis or prostate abscesses. You'll talk about those a little bit later. Prostatic infarctions and manipulation of the prostate. If you're gonna check a PSA level, it's better to have that blood drawn and taken before you go manipulating that prostate, trying to feel its characteristics and that kind of thing, because you can actually make some inflammation there, which can cause the PSA to rise as well. All right. This is an algorithm that I really, really liked. I got it from CMDT, your book, okay? I don't remember which diagram it is, but it basically has a list of what to do when you have a patient that you're evaluating considering BPH, okay? History, physical exam, including digital rectal exam, urinalysis, creatinine level, check that renal function, okay? And if they say a PSA is optional, I would check that PSA. I would make sure and see what's going on. It wouldn't hurt a thing, okay? Quantitative symptom analysis is important. Let's see. And then it talks about mild, moderate to severe, and severe disease. And that's where that table that we talked about before that had the link to AUA can help you, because it can help give you a quantitative measurement of, okay, it is mild, it is moderate, it is severe, and that can help you kind of know what to do, okay? And, you know, there's all sorts of medical therapies. There's watchful waiting, there's surgery, there's medical therapies, and we're going to talk more about those. Watchful waiting. Some men may undergo spontaneous improvement or resolution of their symptoms. Some men may just not want to take the drugs that are associated. For some men, the side effects of those drugs are not something they want to deal with. The side effects of some of those drugs include erectile dysfunction. They may not be having erectile dysfunction with their BPH, but they may have it if you give them the medication, okay? And a lot of guys just won't go through that. Sometimes they can also have hypotension, dizziness, orthostatic hypotension, you know, where they're passing out from those drugs. So you have to be a little bit careful with them, okay? Alpha blockers are one of the medications that are out there. It causes a contractile response on the prostate and bladder neck, and it's mediated by alpha-1A, okay? Prazosin is an example of an alpha blocker. The problem with alpha blockers is that they're not always specific in which exact blocker, alpha receptor that they do block, the medications that is, and you get complete alpha blockade, so you get the hypertension, okay? 5-alpha reductase inhibitors, that's finasteride. They block the conversion of testosterone to DHT. Whenever you do that, you reduce the size of the gland and improve the symptoms. Plants and vitamins, that's examples like saw palmetto that you've heard a lot of people talk about, but there's actually no clinically proven benefit to saw palmetto. And then surgical interventions. Indications for surgery in BPH are refractory urinary retention. Essentially, you can have a patient with their BPH, it's so severe they can't pass their urine, and so you put you put a catheter in there, you give everything some time to relax and calm down, all this good kind of stuff. You take the catheter out, and they're not urinating. You may have to reinsert a catheter. Okay, they may have some diverticula in the bladder itself. Recurrent urinary tract infections with prostatitis, if they're having just infection after infection after infection, you can end up with chronic renal disease from that, so it's better to take care of it, okay? Recurrent gross hematuria, that could be significant. And it could also cloud your judgment in other diseases. It may cloud you from understanding that the patient is starting to have renal problems. Bladder stones and renal insufficiency, of course. Types of surgery that are out there, there's transurethral resection of the prostate. It's probably the most common surgical procedure. There are some post-operative complications of this procedure, and they include retrograde ejaculation. We talked about that before. You can rule it out as a problem by looking for sperm in the urine. Impotence can happen, and then urinary incontinence as well. There are video pieces on transurethral resection of the prostate in Access Surgery, which is available through Loftus Library to every student. There's transurethral incision of the prostate. It removes the zone of the prostate around the urethra, leaving the peripheral portion of the prostate and prostate capsule. So they've had surgery. Part of the prostate has been removed, but they can still develop cancers. Okay. There's also a lower rate of retrograde ejaculation with these patients. Okay. There's open, simple prostatectomy when the prostate is too big to remove endoscopically, or when there's a bladder stone present. There's also another procedure I read about called minimally invasive TULIP, or transurethral laser-induced prostatectomy under transrectal ultrasound guidance. There's advantages: outpatient surgery, minimal blood loss, ability to treat patients while they're receiving anticoagulation therapy. A lot of, think about these older men, they may have cardiovascular disease on top of these other problems, and they're on heparin or different things, and so, or Coumadin, that kind of thing. So that can be an important factor. There's not a lot of people doing that procedure yet, but it is something that your book talks about. Okay. Disadvantages: lack of tissue, because you're not actually taking out part of the tissue. There's a longer... Oops, sorry guys. Let me minimize that real quick. I'm uploading your other lecture real quick. Okay. Oops, sorry. Once again. There's a longer post-operative catheterization time, which the longer you keep a catheter in, the more likely you are to develop infection in the bladder. Patients complain of more irritative voiding complaints, which would be pain, dysuria, and lasers are extremely expensive, and so they're not always used. There's also something called transurethral needle ablation of the prostate. You're going to have very similar disadvantages in that you don't get any tissue from that. Alright. Watchful waiting is most useful for patients with mild symptoms, those AUA scores of 0 to 7. 10% or so of these patients progress to urinary retention, and half demonstrate marked improvement or resolutions of their symptoms. So it can be useful to watchfully wait and not take medications if the patient doesn't want to. And then there is an AUA symptom index for BPH. That's all on that same table that was in the other slide. Alright, now, prostate cancer. Prostate cancer, essentials of diagnosis include prostatic induration on digital rectal exam or elevation of PSA. It's most often asymptomatic, and rarely systemic symptoms present, like weight loss and bone pain. Most patients are screened pretty well these days, so you usually can find out things a little bit earlier. And so here's my question: what does induration feel like? Thick, nodular area on one side of the prostate. Okay. Prostate cancer is the most common non-cutaneous cancer in American men. It is the second leading cause of cancer-related death in men. The first is lung. Okay. Um, there were about 234,000 new cases of prostate cancer in 2006. Okay. Which really is very, very common, but it's actually even more common than what we think. At autopsy, greater than 40% of men greater than aged 50 had occult or undiagnosed prostate cancers. The incidence of prostate cancer increases with age. Risk factors include being African American or black, a family history of prostate cancer, and a history of high dietary fat intakes. The majority of prostate cancers are adenocarcinomas. The signs and symptoms: nodules on exam of DRE, okay, obstructive voiding symptoms, asymptomatic but elevated PSA levels, okay. More uncommonly, you see lymph node mets, lower extremity lymphedema, back pain or pathological fractures, okay, and really rarely signs of urinary retention or neurologic symptoms as a result of epidural mets or cord compression. All the more reason, though, that if you do have a patient that you suspect neurologic symptoms in with no history of surgery in the pelvis, to consider looking for prostate cancer. Alright, so this is that zonal picture again, okay? And so you can see you can develop a nodule in the transition zone infrequently, but they're usually not palpable, and they're asymptomatic when they're very small, okay? As they grow, they can put pressure on that urethra and start to cause problems, okay? And then 70% actually develop in the peripheral zone, and they also can be asymptomatic when small, but you can see you'd be able to feel that much more readily as it's nearer to the surface of the prostate. Screening for prostate cancer includes digital rectal exams, serum PSAs, and transrectal ultrasound, that's TRUS, okay? Detection rates with DRE alone are low. They vary from 1.5 to 7%, okay? Transrectal ultrasound has a low specificity and therefore a high biopsy rate. You know, it can look enlarged. Just looking at it alone with the truss, they can look very enlarged, and so you know you do a lot of biopsies. However, a lot of them are BPH, and so they're not very specific for the problem, and so you have a lot of biopsies and a lot of negative biopsies, which is a false positive. Okay, and that's what you want to avoid. Elevation of PSA is not specific for cancer. It can happen for BPH as well. All cells, a PSA is prostate-specific antigen, and so it's produced by all cells in the prostate, both benign and malignant. Okay, and just remember that 20% of all patients who undergo radical prostatectomy for localized prostate cancer have normal PSA levels, and so you can feel a lump and have a normal PSA. It still needs to be taken care of. Age-specific reference ranges for PSA increase specificity. So, depending on the age of the patient, they have a normal range that's specific to them. So the younger they are, the lower their PSA should be. PSA testing is recommended for all men greater than the age of 50. Consider greater than the age of 45 for African American males. Okay, you should do it annually with a normal digital rectal exam and PSA of greater than 2.5, and twice a year with a normal rectal exam and DRE less than 2.5. Other laboratory tests to consider would be elevations in serum BUN and creatinine, because you're looking at urinary retention and urethral obstruction problems again. Okay, you may see elevations in alk phos, which is especially common with bony mets, or hypercalcemia. Okay, imaging studies, we already talked about transrectal ultrasound. You can MRI the prostate. I don't know if there's much use in doing that. The ultrasound's much more useful and sensitive in that matter. Okay, CT scanning can look for regional lymphatic or intra-abdominal metastasis. Okay, and a radionuclide bone scan can look for bone mets, and that's more common with people whose PSAs have gotten over the level of 20. diagnostic procedures to prove it, instead of like the testicles, you had to take out a whole testicle to prove diagnosis. But with prostate cancer, you can biopsy the mass in the prostate with transurethral ultrasound guided biopsies. And usually you do what they call an extended pattern biopsy, which is a total of 10 samples, which is associated with an improved cancer detection. So essentially, it's an 18 gauge needle on a spring loaded device that you would insert under anesthesia, obviously, 10 times at least, and hopefully get enough tissue to prove cell type. Fine needle aspirates are useful in patients that are considered at higher risk for bleeding, but just from my experience with FNAs in breast cancers and other tumors, FNA typically does not get you enough tissue unless you're like in the thyroid. But even then, they still recommend taking out more tissue to prove diagnosis. With staging, you have to think about, is this disease local? Is it local regional, like in the pelvis? And or are there metastases? Okay. There's a diagram that's probably not going to work if I click this, so I'm not going to click it for you. But you can go to the Lapis Library link through your ECU homepage. You can go down there to Access Medicine. You can look at Harrison's Principles of Internal Medicine and go to Figure 95.3 to see a diagram about staging. And it was too big to fit on this page, that's why I did that. But it just shows pretty much a tumor in the prostate and its local extent. Prostate cancer treatments, surveillance. There are some patients, depending on their age, if their life expectancy is less than 10 years, you may not do anything but just observe that patient and observe them for signs of urinary tract obstruction or different things, and see if you can do anything to give them relief from their obstructive symptoms, but not any additional treatment. Okay. There are medications, some that lower testosterone, some are anti-androgens, some are used in pulsing dosages, which is the intermittent androgen deprivation therapy. Those pretty much cover the chemos that they use for prostate cancer. Okay, and then you have, well, chemo-type drugs. And then radiation is an option for prostate cancer patients. You hear about that a lot. And then a few will have radical prostatectomy. Surveillance is good for cancers that have minimal capsular penetration. Patients who have had standard irradiation or surgery will be surveilled afterwards. For locally extensive cancers, combination therapy can be helpful. And then for metastatic disease, androgen deprivation is helpful. In the medications, you have testosterone lowering agents. They're GRNH agonist, antagonist, which essentially makes a chemical castration. An example of that is Lupron-Depot. Patients will take shots or pills, but usually shots. The Depot is a shot every 3 months. That can help to lower the production of testosterone. Anti-androgens are non-steroidal anti-androgens. They block testosterone flare by causing, they're caused by GnRH agonist-antagonist therapy. They cause fewer side effects than the testosterone-lowering agents. Those side effects being hot flashes, effects on libido, muscle wasting, personality changes, it's like mood swings, less bone loss, and they can cause gynecomastia, though, so you have to be careful. Intermittent androgen deprivation therapy would be 2 to 6 month cycles of the anti-androgen drugs. Radiation therapy is a very common treatment in prostate cancer. You have external beam radiation. External beam radiation is they send beams of radiation essentially to the external surface of your body, hoping to penetrate deep enough into the prostate itself. And the problem with that is that you get local skin effects of radiation, and burns essentially as time goes on, and so it's very uncomfortable, and it's a little bit actually it's a lot uncomfortable to patients. Brachytherapy, transperineal implantation of radioisotopes or isotopes, that is what people a lot of times will call seed radiation, and they implant seeds of radiation in there, and then they treat locally, and that helps to avoid the external side effects and symptoms. This is getting to be pretty commonly used, and patients typically like it because they don't have the external side effects. I've got pictures here. One's just a diagram, an example of how they're inserted into the prostate itself. The second diagram is a picture of how small the little things are. And then the third diagram is a plain film that shows the distribution of those little seeds in and around the prostate, including in the tissues around it in the lymphatic areas, to help prevent the spread of disease. Surgery, radical prostatectomy is for stages T1 and T2 prostate cancers. Local recurrence is uncommon after radical prostatectomy. Adjuvant therapy, radiation for patients with post-surgical margins that are positive, and or androgen deprivation therapy for lymph node mets are the most appropriate. The likelihood of success of surveillance can be predicted using risk assessment tools. These are nomograms for the most part. Memorial Sloan Kettering in New York is a very, very well-known cancer center that creates all sorts of nomograms that are commonly used. This Catan nomogram is one of them. What they do is they combine, you input all this information, the stage of the cancer, the grade, the PSA level, the number and extent of positive biopsies that were taken in your extended 10 biopsy thing, and it will calculate the risk of recurrence, the risk of the risk of recurrence with surveillance alone versus traditional treatment. And so that kind of helps you to figure out, and help guides and directs your care. Death is almost invariably due to the result of failure to control metastatic disease, and so you do have to be cautious with these patients. Okay. Once again, if you guys have questions, I'm going to do my best to figure out how to do discussion boards on Blackboard, and you can send the questions through there. I do have a few scenarios, and they're going to come after this slide. So if you want to take a little break and come back, that's great. But here are a couple of scenarios for you. Okay. Your 28-year-old healthy male patient presents with a complaint of a swollen testicle. He first noted the problem about a month ago, but he thought it would go away without having to show someone his, this very sensitive area. He's a little embarrassed. He denies pain, fever, new sexual partners. He also denies frequency, dysuria, or hesitation. He says he has a normal libido. He actually gets a chuckle out of that question. What's your differential diagnosis? Well, you got a male, and he's got a mass in his testicle. So there are several things that can cause masses in testicles. What's the most common? Hydrocele. And then after that, you have to consider testicular cancer. He's in the right age range, okay? Varicoceles can cause swelling in the scrotum, and testicular torsion. But he doesn't have any pain, so you can probably rule that out, okay? What test or tests can you order to differentiate testicular cancer from hydrocele? Well, the easiest test that you could the best test you can probably order, let's put it that way, is an ultrasound. But the easiest test that you can order right there in your office right that second is a serum HCG level. Some offices have labs that can tell you a serum HCG on the spot. Some you would have to send out, and that may take a day or so to get back. But it's going to take you probably a day or so to get a testicular ultrasound as well and to get your results. And that's here in town. If you're in a small community, it could take a lot longer to get that test result back. Okay, so most likely that patient needs a workup for testicular cancer. Okay. Scenario 2. Mr. B is a 55-year-old African American patient that you've known for years. He's in for his annual physical and notes that he has to get up at night to pee a lot. Upon additional questioning, he denies dysuria, but he admits to frequency and has a feeling that he's just not emptying his bladder well. The force and caliber of his stream are unchanged. But in general, you've known him for a long time, and he just has this problem, and he's just worried about it. Okay? How would you like to proceed? Well, there is a whole gamut of questions you could be asking at this point. Okay? You could be asking, well, does he have an infection? Well, does he have diabetes? Is he peeing, all the time because of that? Does he have sleep apnea? Right? Don't forget those kind of things. but most reasonably, does he have BPH, prostate cancer? What kind of problems are going on down there? So you could proceed most likely with a digital rectal exam. Okay, you could also should proceed with a PSA. Okay, and I would also expect a urinalysis. Okay. What findings would you expect with BPH? I want you to compare and contrast what you would expect to see with BPH versus cancer. Okay, because that's very important. And if you can definitively tell between the two, you're going to be a better clinician. Okay, this one's a little more difficult, but this is scenario number 3. This actually is based on a patient that I have seen in the office before. Okay, Mr. W is a 78-year-old man with multiple medical problems. He has presented to your family practice today complaining of pain in his shoulder. Okay, he's noted the pain before. As a matter of fact, he had an injection 6 months ago that seemed to help. He wants to know if he can have another one. The pain is described as deep and aching. It's 5 of 10 on a pain scale. He describes it as nagging. It happens every day, all different times of the day. There's no one set time of the day or one set action that makes it happen. Okay. He says, it's just arthritis. Can I get another shot? All right. On exam, I'm not going to give his full exam, but basically he's stable. Nothing seems to be changed. His extremities reveal examination of his extremities reveal painful range of motion in the right shoulder and a tender glenohumeral joint. You flip back in his chart and you realize that he had a normal shoulder x-ray 6 months ago before that injection. It was the first time he complained about the pain in the shoulder. You also made a note of his history of prostate cancer diagnosed and treated 2 years ago with seed radiation. And then what additional questions would you like to ask this patient? And I've worked in the non-cancer world and I've worked in the cancer patient world, and there's a lot of questions you need to ask. You need to ask if they're compliant with their medications. A lot of times if they're taking pills or if they're taking even shots, they may have stopped going to get them, or they maybe have been told to stop going to get them. But it's important to ask those questions. It's important to ask who checks his PSA and when it was done last. A lot of patients just get lost to follow-up. They don't want to pay co-pays. They don't want to go in, and so it's really important to know the answer to that question. Okay? What additional labs or studies would you like to order at this time? PSA is reasonable if he's not been getting follow-up. You want to see what his last one was, and you want to see if it's on the rise. Okay? Plain films of the right shoulder are reasonable. It's been 6 months since he had them done. His pain went away with that injection, but the pain is just not exactly typical of osteoarthritis. It's reasonable to check it. Okay, in my patient, I rechecked it because I wasn't really sure what was going on. Alright, this is what essentially we saw on x-ray, okay? And the question I'm asking is, what is this? And I don't expect you to really know what this is right now, but I do want you to see that right in here, and right here, and right here, there, and there, are punched out appearing places in these bones, and that essentially is bony mets. And it's very important to recognize bony mets on x-ray because you might find them incidentally, and it's also important to note that your patient that has prostate cancer may be presenting with prostate cancer in another area of their body when it could very easily get passed off as something like osteoarthritis. I could have given him another injection. It would not have helped, but I could have given him another injection, but he would have been back in the office in no time complaining of more problems. Okay? Alright guys, that really is the last slide. There's nothing else to discuss with this one unless you have questions. So please see the discussion board if you do. Thanks. Hello. Today we're going to be discussing testicular disorders and erectile dysfunction. You'll see there's several objectives we're going to be discussing in detail: testicular torsion, hypogonadism, hydrocele, varicocele, phimosis, and paraphimosis. We're also going to be discussing erectile dysfunction. The first thing is testicular torsion. Testicular torsion is a disease process that involves twisting of the spermatic cord, which can be a very painful condition. Things to consider is that this is considered a urologic emergency. There's a typical sudden onset of pain. There may be intermittent torsion where there's pain that comes and goes, and color flow Dopplers are studies that you can use to see this. Testicular torsion typically happens in a bimodal distribution. It happens in neonates, infants, and babies. It also happens, again, commonly in adolescent males. The left side is a little bit more common than the right, and it's usually preceded by trauma or physical exertion, but it can also be spontaneous. Signs and symptoms: sudden, severe pain, a swollen and tender testicle, nausea and vomiting, usually from the pain. The testes affected usually lies higher in the scrotum because the twisted cord pulls it up. There's also an absent cremasteric reflex, and there is no fever associated with this problem, which can help you differentiate it from some of the infectious causes of testicular pain. In this diagram, you can see a normal spermatic cord, and you can see a twisted spermatic cord. These are examples of what you might see in the clinical setting. On the left, a swollen testicle on that right-hand side sitting higher than the left. On the other diagram is a picture from surgery where you can see the testicle appears to be bruised or ischemic from the twisting of the cord. Treatments for testicular torsion are an immediate consult for urology. Get ready to have that patient go to the operating room, do all your preoperative delays. You can do a Doppler ultrasound to prove the diagnosis if you want, but it may delay getting to surgery, which is not good. Detorsion, or manually attempting to turn that cord back, can be done. There's something called an open book method that involves manipulating the testis so that the anterior surface rotates from medial to lateral as if you're opening a book. From what I've read, in actuality, that's a very difficult maneuver, and it's rarely used. It's technically difficult as well as extremely painful. Once detorsion happens, the pain relief should be immediate, and do not delay operative intervention because testicular infarction or death of the testicle will happen within 6 to 12 hours after the event. Clinical pearls, things that kind of set it aside from other things. That cremasteric reflex is almost always absent. Patients may report similar, less severe episodes that spontaneously resolve. That's that intermittent torsion that we saw in the previous slide. Half of all torsions occur during sleep. That's an important piece of the puzzle. And abdominal or inguinal pain is sometimes present without pain in the scrotum itself. Hypogonadism. Okay, so there's this big axis that controls the development of testosterone and other hormones and androgens, essentially, in the testicle itself. And there's it's the hypothalamic axis, and so you have the hypothalamus producing GnRH, which affects the formation of testosterone in sperm. You also have the pituitary gland, and it's on a feedback loop, so everything is going forwards and backwards trying to make sure that we keep everything in homeostasis. The etiology of hypogonadism, or not enough testosterone, is insufficient testosterone secretion by the testes, decreased gonadotropin secretion by the pituitary, and you can also see this happen with people who drink a lot of alcohol or have Cushing's syndrome or chronic illnesses. The clinical features of hypogonadism include decreased libido, erectile dysfunction, fatigue, depression, and infertility. Signs that you might see on physical exam: diminished sexual hair growth, decreased testicular mass, not meaning a mass like a tumor, but size in general, and loss of muscle mass or muscle wasting in the entire skeleton. Diagnostic studies for hypogonadism include testosterone and FSH levels. Depending on what you see from those results, LH or prolactin. There are two different types of hypogonadism. That's why you need to check the LH and prolactin levels. And this is a nice little algorithm to kind of put it all together. But the number one reasons are where this arrow is. The reason that you check the LH is because you can have hypergonadotropic hypogonadism or hypogonadotropic hypogonadism, and primary gonadal failure is considered hypergonadotropic hypogonadism, and there are some specific disorders that go along with that. Klinefelter syndrome, cryptorchidism, you may see that with those patients. And then in the hypogonadotropic hypogonadism spectrum, you have GnRH deficiency, but you also have hyperprolactinemia, and a cellular mass, which is a mass on the pituitary cell, a pituitary mass. The management of hypogonadism is number one, evaluation for prostate cancer and make sure there's nothing underlying that needs to be fixed. And then testosterone replacement, either orally, intramuscular, or transdermal. Androgel is the form of transdermal replacement, and then there's also just testosterone injections that you can give patients as well. Hydrocele. Hydrocele are a collection of fluid within the tunica vaginalis. Hydrocele are the most common cause of scrotal swelling. They are common in infancy and associated with testicular tumors 10% of the time. So the swelling is not in the actual testis itself, it's in the lining around that testicle, as you can see from this little diagram. And I have some pictures too. Clinically, it's painless swelling. The hydrocele will readily transilluminate. I have a picture of that to show you what that looks like. The patient may describe a feeling like a weight in the testes. Hydroceles can occur with epididymitis, which you're going to discuss in a lecture later in the week, trauma, hernias, and tumors. Or they can just happen on their own. This is an ultrasound picture of a scrotum, and let me see if I can show you. This is the scrotal sac out here. This is the testicle itself in here. And this is the hydrocele on either side. Okay. And this is an infant that has a very similar presentation to this ultrasound. And as you can see, by holding a light to the scrotum, you can see the light comes right through those fluid-filled hydroceles. It's a quick reference point in the office when you're trying to see what's going on. Remember, with hydroceles, there's no scrotal erythema. There's no pain. They transilluminate. It can happen at any age. There's no infertility associated. There's no dysuria, and there's no systemic symptoms of the problem. Varicoceles. This is another problem of the testicle. A varicocele is dilation of the veins within the spermatic cord, or the pampiniform plexus. Clinically, you'll find a soft, irregular, painless mass posterior and anterior to the testes. The swelling can collapse with the patient lying down, and it can refill with the patient standing upright. So that might be an important part of your physical exam, is to, the patient may be complaining about it. They may be laying on the table when you see it, and they may not see any actual problem. When they stand, they may come back. These are pictures of that swelling or dilation in those veins. Here's a diagram on the left, and on the right, sometimes you can actually see the problem like you can on that left testicle. The patient may say that it feels like there's a bag of worms in their scrotum or a weight in their testes. It's a little bit more common on the left, actually much more common on the left than the right, and it usually presents in patients who are over the age of 15. Remember, in differentiating hydroceles and varicoceles and testicular torsion, that varicoceles do not cause erythema. They're usually painless. They do not transilluminate. They are not part of the testicle themselves. They're more common after puberty. There is no pain with urination. There are no systemic symptoms. Sorry for the typo. In older men, you have to also consider bladder and renal tumors, and these can cause infertility due to vascular abnormalities. Peyronie's disease, and I may be saying that wrong. It's been a long time, but this is a disorder that causes a dense fibrous plaque on the tunica albuginea of the penis itself. This is actually a penile disorder, which we're going to discuss more in the next lecture. It causes curvature of an erect penis. On a flaccid penis, you don't see any problems at all, but whenever the penis becomes erect, there's a problem. The etiology of that plaque is unknown. There's possible scar tissue resulting from microscopic tears of the tunica albuginea during intercourse. Actually, I must have had the picture in this one. Sorry, guys. So in the diagram, you can see where they're saying this fibrous plaque forms. This would be on the anterior surface of the penis itself, and then on the right is a picture of an erect penis with Peyronie's disease. All right, erectile dysfunction is a very, very common problem you're going to see in clinical practice. Essentials of diagnosis, direct from your book. Most causes of erectile dysfunction are organic, not psychogenic. Organic meaning it has a medical origin or not just something that's a mental issue. The incidence of erectile dysfunction increases with age, and there are a variety of treatments available, oral, injectable, and mechanical devices. Alright, I made this little table for you guys. Erectile dysfunction is not just dysfunction like you're thinking, where your patient says, oh, I just can't get an erection. You have to kind of distinguish what type of erectile dysfunction am I talking about. Are they saying they have no desire for sex? Because that's a loss of libido, and that is suspicious for an androgen deficiency. Okay, is it truly loss of erection? They are having the desire for sex, but they're not able to hold an erection, okay? And that can be associated with arterial, venous, neurogenic, or psychogenic causes. And within that grouping, you have inability to get an erection, inability to sustain an erection, which can also be helpful in deciding how to treat your patient. Okay, there's loss of seminal emission, or what's called anejaculation. Okay, that can be associated with androgen deficiency, sympathetic denervation from diabetes, or also from surgery. Retrograde ejaculation is something that the patient's not going to come in complaining of, but it's something to look at whenever you're trying to understand what's going on. It comes from a mechanical disruption of the bladder neck, especially following TURP or transurethral resections of the prostate. Okay, it can also happen with medications like alpha blockers, and it can happen with sympathetic denervation, either from disease processes like diabetes or from surgery. There's loss of orgasm, which is typically a psychological origin or psychogenic. Okay, and then there's premature ejaculation, which is usually anxiety related and rarely has an organic cause. General things to consider with erectile dysfunction: inability to maintain an erect penis with sufficient rigidity to allow sexual intercourse. That is the actual definition of erectile dysfunction. Okay, loss of erections, just like we said from the table, arterial, venous, neurogenic, or psychogenic causes. Many problems with erectile dysfunction are associated with concurrent medical problems, especially hypertension and diabetes, which is why we see it so frequently in treatment of patients. It can also happen with patients who have had radical pelvic or retroperitoneal surgery, and those patients are people who have had prostate cancer, testicular cancer, some of the abdominal and bladder cancers, fractured pelvises, lots of different trauma things that can come in there. Okay, you always want to look for concomitant cardiovascular disease. There's more and more data out there that says that erectile dysfunction can be a very early sign of cardiovascular disease. And patients should be worked up to make sure. Other considerations are, what medications is the patient taking, because a lot of the antihypertensive medications can cause problems, okay? Beta blockers, thiazide diuretics are really common causes. So are some of the centrally acting sympatholytics, methyl-dopa, clonidine. Androgen deficiency causes loss of libido and erections, and lack of emission by decreasing prostatic and seminal vesicle secretions. If you don't have your androgens, you're not going to make sperm. You're not going to make the fluids that you need to have an emission. Psychogenic causes of erectile dysfunction are usually anxiety related. Sometimes that's due to a new partner. Sometimes it's due to having, your first partner. Sometimes it's just due to unreasonable expectations of performance. And then also emotional disorders. People who have had trauma in the past or different things, they may not be able to have an orgasm, or they may not be able to even have an erection. So organic causes of erectile dysfunction: vascular causes, endocrine causes, neurologic, medications, alcoholism, and post-surgical change. Let me see what the next slide is. There we go. Okay. Vascular causes: cardiovascular disease, plaques forming in your arteries and veins. All the normal things that would cause you to have angina can also cause you to have erectile dysfunction. Neurologic causes, we talked about that before. Medications, we talked about that. Alcoholism, and post-surgical changes. Sorry for the repeat, guys. Alright, clinical findings, history. You definitely need to go to get history. Erectile dysfunction should be distinguished between ejaculation problems, libido problems, and orgasm problems. You also want to know the degree of dysfunction. Is it chronic? Does it happen all the time? Is it occasional, just now and then? Situational? Is it only with a new partner? Is it only whenever the patient's stressed? The timing of the dysfunction, that's difficulty in maintaining or difficulty in keeping. Difficulty maintaining or getting an erection. Determine whether the patient has any normal erections, especially early morning erections or during their sleep. If they're having normal erections, then an organic cause is less likely. It's more likely a psychogenic cause. Okay. Inquire about a history of heart disease, hyperlipidemia, hypertension, neurologic disease, diabetes, renal failure, okay, adrenal and thyroid disorders, and depression. It's also important to know if your patient's ever had trauma to the pelvis, pelvic surgery, or peripheral vascular disease. Peripheral vascular surgery. And then determine if they're using any kind of drugs, recreational especially, or, of course, prescribed medications, alcohol, tobacco. On a physical exam, look for secondary sexual characteristics: hair growth, general development, are the testicles descended, is everything, are the testicles a normal size, is the penis mature, is it developed? Neurologic and motor and sensory examinations are important. Can the patient feel when you're touching in their perineal area? If they can't feel when you're touching in their perineal area, then they probably have a neurogenic cause. Peripheral vascular examination: do they have a lot of varices in their lower extremities, or do they have a lot of edema? Is there any evidence they have cardiovascular disease? Okay. You also, in males, want to examine their prostate. You have prostatic hypertrophy, but you can also have tumors that can cause some problems down there. Okay. And you want to look for penile scarring, and that's where you get into that Peyronie's disease. A lot of these patients will present, guys, and they're going to just, men are so different. They'll present, and they're either going to be just cocky, literally, stating, oh, I want to be able to have an erection, I've got all these women, and all this kind of stuff, and they're going to complain about it, or they're going to be really embarrassed and they're not going to want to talk about it at all. And it's going to be really hard to elicit this information, so you have to be really you have to be really patient and you have to really ask the questions. You would think that it's enough to say and they're just going to tell you all this stuff because they want help, but it's not usually like that. Most of the time you're really going to have to try and pull the information out of the patient because it's embarrassing enough for them to tell you that they have problems, much less to tell you exactly what the problem is. And it seems to me like they have more trouble telling girls than they do having guys, because it's a guy thing. So don't be afraid to really ask the questions, or to give the patients a questionnaire. There's nothing wrong with a questionnaire that can kind of break the ice and get things going. The other thing to consider is a lot of guys with erectile dysfunction, they just want to fix the problem. They just think that Viagra is going to make them all better, and that's what they need to do. But honestly, there are some labs that you need to consider as well. Okay, a CBC, just their general health, see how they're doing. Okay, a urinalysis is important. You can do a urinalysis with micro. Urine specimens that have sperm in them have retrograde ejaculation, so it's important to think about that. Okay, a lipid profile. You need to make sure there's no underlying cardiovascular disease. Check their risk. Okay. Check a serum glucose, testosterone levels, LH and FSH, prolactin levels. Make sure there's not a pituitary disorder, okay? And you should definitely do those tests if you are worried about loss of libido or androgen deficiency, okay? And so that's what we talked about before, that they may help to localize the site of disease. Imaging studies, you don't really need imaging studies to diagnose erectile dysfunction unless you're worried about vascular causes. And then you can do sorry guys, I cannot say that word. Cavernosography, which is a contrast study of the penis that can determine site and extent of venous leaking. Okay, pudendal arteriography, cavernous arteries, duplex ultrasound. All those are looking just for vascular supply. Okay, there is also something called nocturnal penile tumescence testing. If a patient can't tell you if they're having erections in the night or if they're complaining they're not having erections in the morning, you can do it. I don't know anybody who does it, but you can do it. To help distinguish organic from psychogenic causes. Okay, there are multiple medications that can be used for erectile dysfunction. Hormone replacement is used for androgen deficiency. That's in the medications we talked about earlier. There are urethral suppository pellets that can be inserted literally right into the urethra. They're not as effective as a lot of the other agents, but it is something that's out there. Okay. PDE5 inhibitors can be taken 1 hour prior to anticipated sexual activity. These are the drugs we hear about on the news and the TV all the time. Viagra, Levitra, Cialis. They are contraindicated in patients who are receiving nitrates because they have properties that vasodilate, just like nitrates vasodilate. Okay. Patients who don't respond to one of the drugs may respond well to another. So if they tried one, and didn't have any results, they can try another. You should always try the lower doses first, see how they work before you go on. And there is a specific note here. All patients be evaluated for acute chest pain in the emergency department, urgent care, wherever you are. Should be asked if they're taking one of these drugs before you administer nitroglycerin, so you don't put them into congestive heart failure. There are injectable prostaglandins as well. And they actually say, honestly, that is a wonderful option for treatment. They also say that patients don't mind that you give it with a tuberculin syringe at the base of the penis, and that works, they say very, very well. Priapism is a condition with a prolonged erection, an erection lasting 4 or more hours with no sexual stimulation. Okay, that is considered an emergent condition, but it's also considered rare in patients taking injectables and PDE5 inhibitors, despite what we see on medical TV shows. Surgery is an option for patients who have erectile dysfunction, more for patients who have neurogenic or vascular causes. There are out-and-out penile prosthetics, and there are multiple examples of these you can see in Access Surgery online, by the way, through Lapis Library. Okay, surgical disorders for the arterial system, vascular reconstruction, balloon dilation, and arterial bypass procedures for distal occlusions. Those are all vascular procedures. Okay. There's also a vacuum constriction device. The way this works is that you put this device on, and you has a vacuum seal, and the vacuum essentially pulls blood into the shaft of the penis so that you can actually get an erection, and you put a band around the base of the penis and remove the device to maintain that blood flow or hold the blood flow into the penis, and that maintains the erection, and you remove it afterwards. They say they're highly effective, but they are a little cumbersome, and that patients don't commonly like to use them. And then you also have to know that there's behaviorally oriented sex therapy for men with no organic dysfunction who are having the anxiety related problems. Alright, I made a scenario for you guys. Johnny is a 2-year-old who presents with his mom to your family practice. During a recent diaper change, mom noted his right testicle is huge. She's really concerned. She's been online, and she thinks he has a tumor. He does not seem to be in pain. He has not been ill, and he's not had a fever. Do you have any other questions that you'd like to ask? If I was looking at this with you guys, I would say you should ask questions like, has he ever had any problems like this before? Does he seem to have pain whenever he goes to pee? And just systemic questions. The differential diagnosis is going to include several things. Testicular cancer, it has to be up there. It's an enlarged testicle, okay? Hydrocele, varicocele, torsion, okay? And then infectious causes that you guys have not gone over yet, so I'm not going to put you through that, okay? And at this time, is there anything you can probably rule out? And generally speaking, I would say you could probably rule out testicular cancer, as this patient is only 2 years old, okay? And you could probably rule out testicular torsion because this is not a painful condition. You could also consider ruling out varicocele, but we need to keep investigating a little bit, okay? On his exam, he's afebrile. He's a normal height and weight. He looks like he's developing well. His heart rate and respiratory rate are normal. He's a very active 2-year-old. Your office may never be the same from all the activity that he has, okay? On his abdominal exam, he's non-distended. He does not have any pain in the suprapubic area, okay? On his genitourinary exam, you find a swollen right scrotum, non-tender, rubbery feeling mass. The skin is normal in color and texture. Both testicles are descended, and he does appear to have normal development for his age, okay? There's no edema in his extremities. What do you want to do next? It's an important piece of the puzzle, okay? At this point, at his age, with no pain, and no history of trauma to the scrotum, I'm really thinking that it's probably just a hydrocele, and so I think I would like to do some transillumination, okay? Holding a pen light to the scrotum reveals this. Alright, so that is transillumination, okay? And what do you tell mom at this point, okay? You tell her that this is a hydrocele, that they're extremely common, that they're the most common cause of all testicular masses, that they're benign, that they get better, okay? They're not cancer, okay? And just in general, I want you to be thinking about, how do you differentiate between hydrocele and varicocele? Okay. How do you differentiate testicular torsion from hydrocele? Okay. Hydroceles and varicoceles differ in a mass in the testicle versus a thick mass or a bag of worms type feeling above the testicle and the spermatic cord. Okay. How do you differentiate testicular torsion from hydrocele? Pain, no pain. That's the number one way. Okay. When do you become suspicious for carcinoma? And that's going to lead us into our next lecture, which is on testicular cancer, prostate cancer, and other penile disorders. If you guys have questions, I'm going to do my best to create a discussion board on your Blackboard where you can ask questions.